So coming to the final thing, which is the blood banking. So blood banking, we have to understand the concept to know this. So starting with the formation of the blood antigen. So how do you classify it as a blood group? Okay. So there is something called as a H gene, which is going to be present on chromosome 19. So this H gene is going to encode a enzyme called as fucosyl transferase. So this fucosyl transferase is responsible for transferring a fucose group to a H substance. So there is going to be H substance. Upon this H substance, if there is going to be addition of N-acetyl galactosamine, then it is going to form an A antigen. And if it is a galactose which is going to be present over the H substance, it is going to form a B antigen. If both are going to be present, it is going to form A and B antigen. There is nothing called as AB antigen. Okay, there is both A antigen and B antigen. And if it's just the H substance is present, nothing else is going to be there, then it is going to form the no antigens are going to be formed on the RBCs, right? So when this A antigen is present, obviously the blood group in the serum of the patient, the person itself. So if I'm having an RBC with A antigen, so my serum is going to have the opposite antibody. Okay, so if A antigen is going to be present, I'm going to have anti-B. While B antigen is present, there is going to be anti-A antibodies. Then if there is both A and B antigens present, there is going to be no antibodies. While if I don't have any antigen, A or B antigen, so I'm going to have both anti-A and anti-B antibodies in the serum. So these antibodies are usually of IgM subclass. So remember, the blood group antibodies are going to be of IgM subclass. So how do you determine the blood group according to this? So if I have an A antigen and anti-B antibody, then I am going to have a A blood group. So if B antigen is present and anti-A is going to be antibody is going to be there, it is a B blood group. So if you have both A and B antigen and no antibodies, it is going to be AB blood group. And if you have no antigens and you have both anti-A and anti-B antibodies, it is going to form the O blood group. So this O blood group is going to be the most common blood group, while AB blood group is going to be the least common blood group. So H gene is going to be present on chromosome 19, while this A antigen, B antigen, so the one which is encoding for this A antigen and all, right, N-acetyl galactosamine. So the ABO genes is going to be present on the chromosome 9, while RH gene is going to be present on chromosome 1. So there is something called as a Bombay blood group, which is represented by this O and H. Okay, so Bombay blood group is O and H. So in this Bombay blood group, there is going to be no A antigen, no B antigen or H antigen. So in O blood group, if you see, there is going to be H antigen. There is not going to be any A or B alone. But in Bombay blood group, there is going to be no A or B, and also there is not going to be any H antigen as well. So they are going to have all kind of antibody, anti-A, anti-B and anti-H. So in that case, if you transfuse the Bombay blood group patient with a O blood group, thinking that there is no anti-A or no A or B antigen, then it is going to cause reaction, transfusion reaction. So it is very important to transfuse only Bombay blood group to these patients. Okay, only Bombay blood group can be transfused to these patients. It is called as Bombay blood group. It was because it was first found in Mumbai. So there are so in order to identify the blood group, we do two type of testings. First is a forward grouping, which is used for detecting the antigen present on the RBC. Then we have a reverse grouping, which is used to test the serum for identifying the antibody. So if I am of A blood group, then with forward grouping, then they'll have to find A antigen on my RBC. And when they are testing my antibody, my serum, they'll have to test for the anti-B. Okay, so anti-B antibody should be present. So both must correlate. Only then you can give a proper group. So RH antigen is, we all know, we call it as A positive, A negative, B positive, B negative, AB positive, AB negative, O positive, O negative, right? So in that, positive negativity is going to be determined by the RH antigen. RH gene is going to be encoded on chromosome 1. So RH antigen is can be present on or it can be absent. So in people who are absent, in which they are RH negative antigen, so RH antigen is not present basically. So if RH antigen is not present, they are going to have antibodies for RH. So anti-RH antibodies are going to be there. And the most important thing about this is this anti-RH antibodies are going to be of IgG subclass. So normal ABO antibodies are going to be of IgM subclass, while anti-RH is going to be of IgG subclass. Why is it important? because this IgG is capable of crossing the placenta, right? So when they cross placenta, they can go and cause hemolytic disease of the newborn. Suppose the mother is going to be she's going to be a negative mother. So Rh negative mother having a Rh positive fetus. So in that case, the antibodies in the mother, which is the anti-Rh antibodies, the IgG antibodies, can cross the placenta, and then it can cause hemolysis in the baby who is having Rh antigen. Okay, so that is going to result in hemolytic disease of the newborn. Apart from this ABO blood group system, we also have other minor antigen systems. So what is the significance of this minor antigen is that, so normally we just check for this ABO blood group. So if you check for it, sometimes the patients can have transfusion reactions because there is also presence of some minor antigens in every person. So if the minor antigens are not tested, they can result in transfusion reactions. So what are the minor antigens? So it is of Kell, Kidd, Duffy, Lewis, P system, MN systems. Okay, so these are the other systems of minor antigens. So now coming to the blood components. So if you had donated blood, you must be knowing it. So after donating the blood, they just have 4 bags of it, right? So from the main bag, they are going to separate the blood components. So this separation of the various blood components should happen within 6 hours of collection. Otherwise, they'll be lost. So within 6 hours of collection, you have to separate the components. And what are the components? So firstly, we'll have the whole blood, right, which was taken. So from the whole blood, you can take the packed cells. So packed RBCs can be taken. And then you can have the platelet concentrate. So you can take the platelets separately. Then you have the plasma. So fresh frozen plasma can be there. Then you have something called as cryoprecipitate. So we have other blood products as well. I'm not going to the details there. So coming to whole blood, this again is going to be important. The temperature of the storage and the shelf life of it, then the contents of it is going to be important. So if you infuse a whole blood to a patient, if you are giving 1 bag of whole blood for a patient, it is going to increase the hemoglobin by 1 gram per deciliter. So 1 pack of whole blood is going to increase the hemoglobin by 1 gram per deciliter. And you have to store this whole blood at a temperature of 2 to 6 degrees Celsius. And you can store it for 21 days or 35 days or 42 days based on the anticoagulant present in that. Okay, so we have 4 basic kind of additives, preservatives in that. So first one will be an ACD, second is a CPD, then we have CPDA, and third one is SAGM. So ACD is nothing but acidified citrate dextrose. Then CPD is going to be citrate phosphate dextrose. So ACD and CPD, you can use it for 21 days. If that is the preservative added, so you can use it for 21 days. And CPDA, if you use it, you can use it for 35 days, store it for 35 days. SAGM, if you had added SAGM, you can use the whole blood for 42 days. So this is important. So what is the function of each of these components is that, so citrate is going to be, it is a calcium chelator. Okay, citrate is used for calcium chelation. Phosphate is a buffer, and dextrose is for nutrition providing to the RBCs. Okay, and CPDA, it is the same CPD plus you have adenine. So adenine is used for increasing the shelf life of the whole blood. So here it is actually providing with the ATP. ATP is going to be there in from adenine, and it is used for the viability of the cell. And SAGM is going to be saline adenine glucose mannitol. So saline is going to be for maintaining the osmosis of the thing, and then adenine is again for ATP viability, glucose is for nutrition, and mannitol is going to decrease the lysis of the RBCs. So SAGM is going to be the best one because you can store the blood for 42 days. So packed RBCs, so like whole blood, this packed RBCs are again stored at a temperature of 2 to 6 degrees Celsius for 42 days commonly. Again, based upon the preservative, you can use it for 34 or 25 days. So 42 is commonly we use it. Then platelet concentrate. So platelet concentrate, it is going to be stored at a temperature of 20 to 24 degrees Celsius. Basically, it is a room temperature, right? So room temperature with continuous agitation. That is, if you had seen it in the blood bank, the machine will be continuously agitating like this. The blood bags will be kept on it and the machine will be continuously agitating so that it doesn't form a clot. So 20 to 24 degrees Celsius with continuous agitation, and you can store it for 5 days maximum. So after 5 days, you'll have to discard the bag if it is not used up. Okay, since it is going to be stored under room temperature, this is the blood component which is maximally prone for bacterial contamination. Rest all is stored in the fridge. So this is the one which is stored in room temperature. So it is the most prominent, mostly involved with bacterial contamination. So fresh frozen plasma, here it is going to contain all the coagulation factors. So except for factor 5 and 8 usually. So all coagulation factors are going to be present here, and this can be stored at minus 18 degrees Celsius for 1 year. Okay. If you see the cryoprecipitate here, it is going to contain specific coagulation factors alone, that is factor 8, von Willebrand factor and fibrinogen. So only these three things are going to be present, and this again can be stored at minus 18 degrees Celsius for 1 year. Okay. So there is something called as massive blood transfusion. So massive blood transfusion is when you are going to infuse more than one blood volume of components within 24 hours. So one blood volume is going to be around 5 liters, right? So 5 liters of blood. So various components you can mix it. So 5 liters of the blood you are going to give to a patient within 24 hours. So that is quite massive, right? So that's called as massive blood transfusion. It also has another definition. If you transfuse more than 50% of the blood volume within 4 hours. So within 4 hours. Both the definitions are true. Okay, and in child, if you transfuse more than 40 ml per kg, that is also considered as massive blood transfusion. So what is the complications occurring with this massive blood transfusion? The main thing about this is going to be dilutional coagulopathy. So the blood component and the plasma levels are going to be mismatched. So it is going to result in dilution coagulopathy, resulting in DIC in these patients. Apart from that, there is going to be hypocalcemia. So lots of blood components are going to be there, which is going to contain some anticoagulant, which is going to cause calcium chelation, right? So hypocalcemia will be there. Apart from that, they can have both hyperkalemia and hypokalemia, but hypokalemia is much more common. Same for hypoglycemia. So hypoglycemia is much more common than a hyperglycemia. Okay. Then you can also have metabolic alkalosis and hypothermia. Okay, so all of these are complications of massive blood transfusion. So normally, if you are doing a massive transfusion, there is set protocol in which you have to give the blood components. So usually we follow RBC to plasma to platelet ratio of 1:1:1. For every one bag of RBC, you have to give plasma and then one bag of platelets. So that is how they do it in a massive transfusion protocol. So lastly, we'll see about the transfusion reactions. So if you are issued the blood and there is going to be some reaction, we call it related to the blood transfusion, is going to call as transfusion reaction. So if the reaction happens within 24 hours, we call it as an acute transfusion reaction. More than 24 hours, we call it as a delayed transfusion reaction. So under acute and delayed, it is again classified into immune mediated and non-immune mediated. So under immune mediated, the most common, or in general also, the most common transfusion reaction is going to be a febrile non-hemolytic transfusion reaction. So just like that, they will not have any hemolysis. Just like that, they will just develop some kind of fever. So transient fever will be there. So this is the most common transfusion reaction. Apart from that, you can have acute hemolytic transfusion reaction if there is going to be an incompatibility of the blood groups. So that can cause acute hemolytic transfusion reaction. Then subtle urticaria and also life-threatening anaphylaxis can also happen. Then there is something called as TRALI, transfusion associated acute lung injury. So here there is going to be lung injury. The patient is going to complain of dyspnea and everything. So this reaction should happen within 6 hours of blood transfusion. So only when it happens within 6 hours, you can label it as a TRALI. And this is going to be most commonly associated with FFP. And this reaction usually happens due to leukocyte antibodies. Okay. Then under non-immune mediated reactions, you have sepsis. So sepsis usually happens with bacterial contamination, right? So bacterial contamination, the most common product was platelet concentrate. So when you are transfusing platelets, if you are keeping it for outside for a long time and then transfusing it, the patient can develop sepsis as there is chances of a bacterial contamination in the platelet bag. Other than that, non-immune hemolysis because of physical trauma. So if it is going to be damage to through the veins, so that can cause a mechanical trauma to the product. So that can cause non-immune hemolysis. Then TACO, transfusion associated circulatory overloads that can be resulting. Then air embolism, while transfusing, the air can enter into the vessels causing air embolism. Then in delayed transfusion reaction under immune mediated, you are going to have a delayed kind of a hemolytic reaction. So after 24 hours, suddenly the patient can have a delayed transfusion reaction. Then GVHD, graft versus host disease. So the graft is going to attack the host here. And then the non-immune mediated delayed transfusion reaction, you are going to have iron overload, especially in thalassemia patients when there is lots of blood transfusion happening. So it can result in iron overload. So this transfusion reactions, the most important thing is the febrile non-hemolytic transfusion reaction and the TRALI. Okay. Then finally, we have transfusion transmissible infection. So we call it as TTI. So what are the infections we check for after collecting blood from the donor? So once we collect the blood from the donor and before transfusing it to the patient, we are going to check for certain blood transmissible infections. So what are they? They are going to be HIV, HBV, HCV, syphilis, and malaria. So these 5 are going to be tested commonly. And this malaria is going to be the one which can transmit through all blood components. So malaria can transmit through all blood components.